My name is Tanya, and you're here for the Early, Safe, and Sustainable Returning to Work After Injury and Illness webinar. This is the third webinar in our new series, Return to Work, Stay at Work, and we're very glad to have you all here. And our presenter today is Douglas Kube. Mr. Kube works with clients to identify and prioritize risks and to help them understand the human, social, and economic costs of disability. He is a senior consultant with Stantec, and he works with employers to develop programs that maximize savings in averted regulatory fines, reduced workers' compensation, and disability costs, leading to improved employee health, engagement, and performance. He has over 20 years of experience in many sectors, including aviation, aerospace, courier and mail, transportation, warehousing, healthcare, pharmaceutical, chemical, steelmaking, and insurance. He has also been a member of our board of directors at the Canadian Institute for the Relief of Pain and Disability since 2006. So I will go ahead and hand it over to Doug.
Thank you, Tanya. And thank you, everybody, for joining us this afternoon or this morning, wherever you are in the world. And what I'd like to do today is share some of my experience with you in this topic of early, safe, and sustainable return to work, some of what we've learned over the last few years, and what I've learned both as a consultant but also as prior to joining Stantec, being the Director of Occupational Health Services at Air Canada, and prior to that I was the Director of Environment, Health and Safety at Purolator Courier. So a lot of what I'm going to share with you are things that we've learned over time in terms of implementing return to work programs. The learning objectives for today are as follows. We really have 4 learning objectives that we hope by the end of this webinar you should be able to describe the best practices used by progressive companies to support early and safe return to work by employees. I'd like to hope that you will be able to employ some of the basic tactics to overcome some of the barriers that are related specifically to the medical system and treating physicians. That's an area we're going to cover in a little bit more detail today because it's an area where a lot of the clients I speak to continue to struggle with some of those issues. And hopefully by the end of this you'll be able to explain some of the proven strategies in return to work and accommodation and disability prevention. And then lastly, we'd hope that you'll be able to identify some of the benefits of improved return to work, which include reducing costs to the employer, to the individual who is disabled themselves, as well as to society. Yep. One of the things that we looked at in disability we looked at recently is how things have changed so much in the last 10 years. And if you think back 10 years, the past 10 years we've really come a long way, but we still have a long way to go. When we sat down and kind of talked about where we were 10 years ago, we started looking at it and realized that we have come a long way in the sense of in 10 years ago we had a model that was very much a medical model. There was a very legalistic disability adjudication type system where adjudication was really done more based on the law or the policies of the organization. There was a clear focus on fraud identification and management. A lot of employers had the belief that individuals who were making claims, whether it be with the Workers' Compensation Board or on short-term disability, may not be legitimate, and that they needed to have a process to make sure they identified and managed any fraud. Return to work programs were primarily driven by workers' compensation boards. Many organizations weren't returning folks who were off on STD or LTD to work, or didn't have programs, at least formal programs to do so. 10 years ago, there was a real focus on time and attendance policies in the HR world, and accommodation was more focused on hiring practices and thinking about accommodation as hiring an individual with a disability or accommodating based on the grounds of religious freedoms. And then we started to see issues that were starting to emerge, specifically the concept of presenteeism. It began to emerge about 10 years ago, as well as workplace stress and mental health issues started to emerge as a real human resources issue. And if you think about it now, think about your own experiences and take a minute to reflect on it, and think of what you've seen over the past 10 years. How has it changed? I'd encourage everybody to take a minute and sort of jot down one or two ways that you've seen this this field of work disability or disability management. How has it changed for you in the last couple of years? You bring the clock forward 10 years. One of the things that we've seen, I think, in the last 10 is the evolution to more functional medical model of return to work, moving from that true medical model focusing on the diagnosis and the individual's medical problem to starting to look at concepts of functionality and what can an individual do regardless of their medical diagnosis. Today we're also focused on, very heavily, I think in the last few years in particular, have been focused on physical changes in the workplace, as well as the objectification of the impairment. Workplace stress, work-life balance have become major sources of impairments, and they're really starting to take over as in the #1 spot, probably, in taking over the physical impairments. And just in the last few years, we've also seen a real increase or a real focus on issues such as privacy, as well as the employee's responsibilities and the employer's rights to medical information. It's become a significant issue and still remains a bit of a barrier for some organizations. We're going to talk about some of those issues later. There's a recognition that there's a large financial cost associated with work disability. And I think most organizations today have come to the realization that the costs are significant and that they do need to be managed. There's also become a very strong recognition of the link between health and productivity, and I'm going to talk about that in the next slide. And it's something that Towers Watson has done some really interesting research on, and a lot of organizations are starting to figure out the link between, the correlation between health and productivity. And lastly, employers are focusing on business performance metrics rather than return on investment, or ROI, as a success metric for return to work programs, which I think is a real positive, because a lot of organizations would try to justify the investment in return to work programs based on a ROI, or a return on investment, and without recognizing or taking into account that linkage between the health and the productivity and business performance. So we're starting to move in the right direction to start looking at how it directly affects business or organizational performance itself. I mentioned the Towers Watson research. Towers Watson has been looking at health and productivity for probably at least 10 or 15 years that I've been watching it. And one of the things that they come out with recently in their report last year, when they looked at 2009, 2010, or the 2009-2010 staying at work report, was that there's really, we have seen a growth in particularly senior management's recognition of the link between health and productivity. And they've now published some research that suggests that employers with the most effective health and productivity programs experience better human capital and financial outcomes. And there's some specific measures there that I think are quite significant. If you look at organizations who have the most effective programs, they see an 11% higher revenue per employee, and that's that link to business performance. They see fewer absenteeism days, 1.8 fewer, 28% higher shareholder returns, which is really interesting. Maybe a bit of a stretch, but there seems to be enough research to support that there is a higher shareholder return in organizations who have the more effective health and productivity programs, and that they're more likely to have lower health care costs, lower levels of presenteeism, fewer lost days due to disability. So I think it's exciting now that we have some research out there that we can take to the boardroom and explain that it's true. There's clearly a link between health and productivity. We have a better understanding of it, and we're now able to start looking at how to better invest in intervention. The next slide I put up is one that we used quite effectively at Purolator when we were training management and senior management on how we wanted to approach the strategy of return to work. And the way it works and the way I explain it to individuals is to say that we have to look at work disability and work disability prevention over time. And if you think about that linkage between health and productivity, think about an individual on that black line that starts over on the left by the positive sign. They're going along, they're moving along over time in that green zone. They are productive, they're doing well until a point where they hit an impairment. And that impairment might be a strained back, it might be a diagnosis with diabetes, or it might even be a social type of issue where they have a death or an illness in the family. At some point they hit this impairment and some point in time, and then their productivity in some cases starts to suffer. And as productivity goes down, they eventually hit a point where they become work disabled. They are at the point where they can't be at work anymore, and they decide or opt to take advantage of the programs that are there to support them, whether that be workers' compensation, sick days, short-term disability. At some point they go below that line and they're now off work, and they're in the negative zone on productivity. And over time, hopefully shorter time, they come to a point where they then return to work, and that's where our accommodation process typically begins, somewhere in that range. And the importance of this visual is, one of the important parts of this visual is you have to start looking at it over time and saying, we need really three strategies. We need a prevention strategy. What can we do to prevent individuals from encountering that impairment, whether that be wellness programs or other types of programs that can support individuals. We need an early intervention strategy, which is to focus on activities or interventions that can be applied in that phase before they go off work, hopefully to keep them in work. And then we need a return to work strategy. We need a strategy to catch those individuals who have had to go off work and get them back to work in safe, suitable duties. If you think about the early intervention strategy, what we're really trying to do is to turn that line back up to that dotted line that I'm showing, to get them back to work or get them back to productivity, and to support them through that phase, and to support them on an ongoing basis, and to keep them at work and productive, which most people want to do. And the other situation, the second dotted line I've added, is really illustrating how we want to turn that line up as quickly as we can and get them back to work and again back to productivity. And really what we're talking about is that duration that I'm showing there between the point where they go off work to return to work. The real objective here is to simply reduce the duration in the return to work process. Let me switch gears for a second now. There's been some really interesting work that Dr. Mark White at the CIRPD has published recently that I think is really exciting for those of us who are looking at the research. And Dr. White published this paper that you can see referenced on the bottom, which was a synthesis of systematic reviews. And when we looked at this, the literature that was out there, and focused on factors that were predictive of disability. What were the types of factors that predicted disability? We found some very interesting things. As we looked at modifiable factors and looked in the workplace, what we found was that there was very strong evidence to suggest that lack of social support, job strain, increased physical demands, low job satisfaction, lack of supervisory support, and so on, these factors were predictive of disability. Now, when you look at that list, one of the things that stood out for me was that we didn't see, we saw a lot of social types of issues and psychosocial types of issues in the workplace. When we looked at the worker, we found strong evidence that emotional distress, increased depressive symptoms, lack of family support, increased pain, increased fatigue, those were the factors that were predictive of disability. And again, these are modifiable factors. So when you think about this, we're looking at both the workplace and the worker. we're looking at what are the modifiable factors, what can we influence in terms of factors. And what the research showed was these were the kinds of factors that are modifiable and that were predictive of disability. Again, the interesting part of this to me was that a lot of what we were looking at were, again, more psychosocial types of issues. Now, some of you are probably saying, well, we've known that for years, and I think anecdotally many of us have. We've recognized the importance of this. What I'm excited about with this research is that we've got a really strong paper now published that has gone and looked at the literature out there and provided us with some really good, strong evidence to support what many of us have known in practice. So when I look at that research, one of the things that I found interesting and exciting about this is that we can now start looking at how do we intervene, and some of the recommendations that Dr. White, or some of the findings that Dr. White had in the paper, were that intervention should target evidence-supported modifiable predictors of work disability, those that I had just shown you, and that the vast majority of risk factors are cross-diagnostic and greatly influenced by psychosocial and/or organizational factors. The next line was really interesting to me too, because he indicated that yet disproportionate resources are expended in policy and occupational practice to make physical changes to the work environment and to objectify the impairment. So we spent a lot of time in the last couple of years trying to make the physical environment right for individuals and to support them. We spent a lot of money on ergonomic programs and making sure the physical changes that are made were supporting the individual. And we've spent a lot of time trying to objectify the impairment to make sure that we get independent medicals completed, make sure the individual gets the right diagnosis. But at the end of the day, what this research suggests that we may be focusing a disproportionate amount of resources when we maybe should be focusing more on the psychosocial risk factors. And as it says here, the psychosocial risk factors, although more difficult to capture, need to be targeted in future models. And it's something from a workplace perspective, I think we can all think about how we need to start looking at what is the healthy psychological workplace or psychosocial aspects of the healthy workplace. Research also suggests that multidisciplinary perspective is needed for managing. I think we all know that. And that although the medical model has provided a traditional basis, the physical and psychosocial predictors observed support what Dr. White called more of a biopsychosocial model. And this biopsychosocial model really looks at recognizing that there are contributors that are biological, psychological, and there are social factors that are important. And we have to find a way of balancing and understanding those as we try to develop programs for return to work. So let me take that and sort of turn back to practice and think about what we need to do in order to manage work disability. And if you think about those of you on the phone who may be, or on the webinar, who may be practitioners, who may be in a workplace, or who may be managing cases or claims, my question for you is, what do you need? What do you need to manage a work disability? Someone is disabled, they're out of work, they call in and say, I'm sorry, I can't come to work because I have an illness or a disability. What do you need? Where do you start? Well, the first place most people start is a diagnosis. One of the things we want to do is ensure that if the individual is ill, they get medical attention, they get a diagnosis. For psychological disorders, we want to make sure that they get properly diagnosed with a DSM-4 diagnosis. For others, using the ICD, point is too many individuals seek medical attention and don't get diagnosed early enough, and that's something that really needs to be looked at. So most programs, most return-to-work programs and most disability programs are geared to ensure that there's a diagnosis to start. But we also need to understand what is the prognosis and what is the treatment. Now, as an employer, you don't have the right to know the treatment, but what's really important is that we try to ensure that individuals are in treatment and are getting treatment and are participating in their treatment, particularly in mental health types of disorders and issues. We see so many individuals who aren't getting treatment or who don't continue their treatment, and then their prognosis obviously gets, or not obviously, but in many cases their prognosis gets worse. The other thing we need to do to manage disabilities, we need to know the job demands. What is the individual doing for their job? Are there high physical or psychological demands of the job? And we need to understand them. We also need to understand the barriers. And this is where it comes back to Dr. White's model of the biopsychosocial. Quite often what we find in cases is that the individual may be sick, they may be injured. There may also be interpersonal or relationship types of issues, the psychosocial factors in the workplace, things like they don't get along with their manager. And there may be process issues as well. They don't know how to do the job. And I've seen this many times where individuals become stressed and come to a point where they can't stay in the workplace because they haven't been taught how to do the job properly. So there are a whole lot of process issues you want to understand when you're thinking about how do you manage these cases and return people to work. The other thing that you need is the resources. You need a return to work coordinator, and most clients we work with today, we stress very highly that they think about as having a process where there is a return to work coordinator in place. You need case managers, you need a supervisor. You need the supervisor to be engaged in the process. And you also need the medical support that I've listed there. And one of the other things you need that becomes very important, particularly when we look at the psychosocial aspect of this, is you need employee commitment to actively manage their own health. And as I said in the beginning, they need to manage their own health and participate in their treatment and the return to work plan. So it's imperative that we not only have the employee committed to this, but we also have the employer committed to support the employee through this process. So when you think about this from a very simplistic case management perspective, those 7 steps or 7 things that I've listed are really what we need to know in order to manage those disabilities. I want to talk a little bit now about best practices. And one of the things that that we've looked at in my company and in the work we've done is we've started to try to look at the clients we have and the companies we work with and look for those best practices to try to make sure that we're communicating those to other clients and helping clients to kind of work to improve their systems and to look outside their own organization. What we've found when we've looked at these is that the companies who are really good at this tend to have a comprehensive approach to managing work disability, meaning a comprehensive approach of looking at sick days, STD, workers' comp. It doesn't matter what program they're on, they look at it more as a comprehensive program. There's generally a formal management system and governance process, meaning there are policies and procedures, and there are systems and forms in place that make sure that it works. We generally see programs that try to avoid discretionary time away from work, and that's something that I think is evolving and really growing in the last little while. But too many employers we've seen in the past when we've looked at it where individuals can go off work without providing any justification, and that not only isn't good for the employer, it's not good for the employee if they have a true disability or illness. We want to make sure that there is a process by which they can take advantage of their benefit when they need it, but we don't want to allow it to be too discretionary. We also see organizations who have consistent policies, whether it's for incidental, personal, disability, or work-related absences. They have true early intervention strategies where they intervene very quickly. That was probably one of the most important things I would say is when I look at clients, is one of the first things I look for is whether they have an early intervention strategy. They use data to target the top preventable absence-causing illnesses. One of the things we did at Purolator is we looked at the aggregate data on our short-term disability to try to understand what were the top preventable absence-causing illnesses and what could we do in terms of investing in healthy workplace or wellness programs in those areas. Leading companies usually have disease management coaching sessions to support accommodation of employees with chronic conditions. This is something that's really growing where we're seeing a lot of older employees or a lot of older individuals, or individuals not even older, but who are starting to develop chronic conditions such as diabetes or chronic heart disease, those types of conditions. And leading companies are starting to engage support from organizations who can kind of help those individuals and coach them and help them to manage their conditions. Leading employers have comprehensive methods for ensuring or for measuring and monitoring. And I'll talk a little bit more about that, but the measuring and monitoring of this is so critical. If it's not measured, it doesn't get done, as we know. And another thing that we're seeing that something we do a lot of is that clients who are really good at this tend to regularly audit their program effectiveness and compliance. They not only audit their program to verify they comply with the legislation, but they're auditing to verify that the procedures and processes they're putting in place are working. And if they're not working, then they have an opportunity to adapt them. And lastly, the leading companies that I've seen in this have a system where they report information, data, measurement, and audit results to senior management and right up to the board of directors. We worked with a very large Canadian organization recently who really was able to start improving and some of the things they were doing because they had some very knowledgeable people on their board of directors who were asking the right questions. And if you can get it to that point, they start to look at it from a business perspective, but there's also some very sharp people at the board level who understand the risks and what needs to be done to improve them. I've talked a little bit on this slide. I wanted to share a little bit more on what I meant by management systems and governance. One of the things we've seen in leading companies is that there's a system, and the system starts with commitment, and that's usually done through policy. There's a planning process where they, on an annual basis, look at what they want to budget for work disability prevention programs or return to work programs. I try to identify, as I talked about earlier, the top illness-causing types of conditions or diseases that they want to focus on. There are procedures and records and training to implement the program, and there are ways of measuring, scorecard types of measurements, where they can actually measure sort of key indicators to make sure that they're tracking and moving in the right direction, and able to at some point when they need to, be able to change course if they need to. And as I said, annual audits, a real critical component to audit to make sure your program is working. I mentioned metrics and key performance indicators. Leading companies we've worked with usually have a scorecard of a whole set of different types of indicators. They range from everything from incident rates, such as workers' compensation, injury, illness rates, short-term disability, illness and injury rates. They look at percentage of claims that are psychological versus physical. Cases of employees missing work, so when we want to look at things like lost day severity rate, number of lost days per 200,000 hours worked. They also track the number of accommodated or transitional or modified days, and again, some of the leading organizations I've seen tend to do that on a per 200,000 hours worked. They track permanent and temporary accommodations, and that's something that we looked at very seriously at Air Canada, was looking at trying to understand, what is the difference between somebody who's being accommodated on a temporary basis versus a permanent basis. And you need to measure that. You need to know that, because it's important to help you manage the business, but also it's important to help you to manage that individual whose impairment is probably not going to get better and may get worse. One of the key metrics that I've seen some good organizations use is median disability duration by claim type. And this is a really important one when you look at psychological or mental health conditions. What this is really looking at we've used this before, where we've looked at what is the average number of days off for depression, and then compare that to the clinical guidelines or some benchmark to be able to try to identify whether those cases are being managed well or not. And being able to look at things like delayed recovery rates, percentage of cases extended past those optimal healing times, is a really useful way of tracking and understanding where things aren't working and where disabilities and time off is driving cost in the organization. It's also really important for the individual to understand that perhaps their treatment isn't working. So when you boil it down to an individual basis, you can look at the Presley-Reed or the ODG guidelines and be able to say, you know what, the median length of time off for carpal tunnel should be 14 days, and this individual's been off 6 months. Well, something's not working then. They either got the wrong diagnosis, or their treatment isn't working, or perhaps they're still waiting for surgery. We'll talk about some of those issues. And also, leading companies tend to normalize all of their KPIs, all of their key performance indicators, as a function of productivity, whether that's the number of widgets made, or in Purelator's case, the number of packages shipped, or in other organizations, they can look at whatever their normal measure of productivity is. One of the things we mentioned earlier is I mentioned at the beginning, was the fact that many of my clients and many people I speak to have a real difficult time in dealing with the medical system, and seem to think that treating physicians are a major barrier to return to work. And I think it's improving, but I think we have to recognize that some of these challenges that we face, particularly as practitioners who are trying to, or return to work folks, people who are case managers, we have to recognize that the challenges go well beyond the worker in the workplace, and that there are some system-based challenges with the medical system. We know that there are issues like timely access and wait times for treatment. It takes time to get in to see certain specialists. There's access and delays in treatment, particularly for mental health issues, and we know that it's hard to get access to individuals like psychiatrists. We see wait times for diagnostics for things like MRIs. And one of the other things we see when we've looked at this is that the role of the treating physician in facilitating the return to work is something that I think is not well known by many physicians, and tends to be, kind of at the root of what the barrier is in the healthcare system at times. Now, one of the notes I made here was that the Canadian Medical Association has created an excellent return to work policy. Speaking of 10 years, I think it's over 10 years old now. It's been around for a while, but there's not a lot of I think we still have to do a better job of training and educating physicians on that policy and what their obligations are and what their role is. And there are really limited evidence-informed resources to support physicians in managing return to work. And one of the other issues that I think many folks deal with on a regular basis is the physicians are in some ways caught in the middle. The treating physician has to think of their role as a patient advocate. So are they a patient advocate, or are they doing the right things for their patient? They have to look at issues of patient confidentiality. So you have to recognize that physicians have a role in advocating for their patient and doing whatever's best for their patient. And the fact that you're calling them from the workplace saying you want information or want that individual back to work, that's really not their objective, or they don't think it's their objective in many ways. Other barriers for physicians, when we look at the treating physicians out there today, they're not trained on work disability prevention. Most medical schools don't have anything on disability prevention, work disability prevention. They, as I said earlier, although the CMA guideline mentioned it, there's a real lack of their understanding of their roles. They're not equipped to determine functional restrictions, and this is where many leading organizations I've seen seem to work more now with, on the functional side, with physiotherapists and occupational therapists to help them to look at functional restrictions and limitations, and I think physicians appreciate that resource when you offer it. There's typically a lack of information. In most cases, physicians don't have the information on exactly what the individual is doing on the job. And I'll tell you a funny story out of one company I worked with, which is a courier company, that we had an individual who came back to work, and actually wasn't coming back to work. And when they contacted the physician said, you know what, I think it's absolutely crazy that you make this individual lift 10,000 packages an hour. And when we explained to the individual what the real job demands were, the physician felt, I think, a little embarrassed and kind of went, yeah, I should have thought about that one. 10,000 packages per hour is quite a bit. But I just want to use that to illustrate that the physician's working with whatever information the individual gives them in many cases. So if the employer isn't providing a document which includes the job demands, then what does the physician have to work with? We also recognize that the time with the patient is very limited for physicians. I mentioned earlier they feel caught between the parties, and many times they're not using evidence-based, scientifically validated, outcome-focused treatment guidelines, and that's something that those of you who are health professionals and work with a treating physician can help to influence. So overcoming these barriers, what we've seen in leading companies is early physician communication, assist them in understanding the job demands, as I said, other social and environmental factors. Treating physicians need to know what other kind of psychosocial factors exist and what may be influencing the patient's absence behavior. You want to focus on functional information and the social factors, going back to Dr. White's research. We know that we need to focus more on issues of functional and social factors. We need to encourage a prompt diagnosis. When we can, we need to provide timely and appropriate advice and guidance for employees and an ongoing liaison with the workplace. And this is where, if you can work with the physician, if you are an OC health nurse, for example, you have the ability to inquire about diagnosis and to try to help them ensure that they get the right diagnosis and get the right treatment. Need to offer help in determining functional restrictions and abilities. As I said earlier, physicians, I think, appreciate the fact that you can have the individual evaluated functionally. Offer services of other services that are typically available through employers, such as EAPs. We've seen many companies who have started to work more with physiotherapists and rehab clinics. And although may not be covered by your provincial health care system, many employers are starting to recognize the value of those and are willing to pay. We also need to explain to the physician that services are available, and many times the physicians don't realize that there are services available, and the physician can play an important role in coaching and encouraging the individual to take advantage of those services that are available to them. And work-disabled individuals need an advocate, and one of the things I strongly believe is whether the individual is going to the family physician or the treating physician, or whether they're going to a specialist, or whether they're going to rehab, or whether they're going to a meeting with their employer or the workers' compensation board, it's important that they have an advocate, that they have support and they have help. And we've seen some unions have been very good at investing in training their folks to kind of help, to be able to help their members to advocate on their behalf. And I think that's a really valued service that can be provided to the individual. I've talked a lot about employers, I've talked a lot about the healthcare system. I also want to provide some solutions or advice to work-disabled individuals, because I think this is something that, again, as I said, the unions play a big role in advocating and helping individuals, but I think many folks who are work-disabled need some advice in terms of how to move forward and how to make sure that they navigate the system the right way. First, I would say that you need to know your rights and your responsibilities. That's really important. Understand your rights, understand what you're responsible for and what you're supposed to be doing. Make sure you provide the documentation to the healthcare provider or from the healthcare provider to your employer in order to make sure that we have evidence to be able to clarify those restrictions. We need to request, the individuals need to request accommodation. They need to come back to their employer and make that request. They need to participate in the discussions, make suggestions on possible accommodation solutions, listen to and consider other reasonable options. Individuals who are work disabled really need to take responsibility and manage their own health, and as I've talked about before, participate in their treatment. You need to participate in your treatment, your return to work plan. You need to make sure that you're in active rehabilitation, meaning rehabilitating on the job. That's what we're starting to learn, is that that's really critical to successful return to work and rehabilitation. and plan to progress from lighter to heavier tasks. Advise your employer of changes in accommodation needs as you think you can do more, or as if you can't do more and you think you need to do less. You need to communicate that. And you need to return to your therapist or your medical provider if you're not seeing progression and improvement. And that's something that I think happens all too often in organizations, is that individuals sort of stagnate on return to work plans and they don't see progression. And if you're not progressing, then you need to return to your medical provider and ask why. There may be a good reason for it, but hopefully if we have the right therapy, the right treatment, and we have the right return to work plan, meaning an active rehabilitation, return to work on the job, hopefully we'll see progression and improvement, and that's usually the goal. I also wanted to provide a little advice for physicians. I've talked a lot about these issues, so I'll move through them relatively quickly, but I think it's important that physicians really start by understanding their role. And the sub-bullets there come right out of the Canadian Medical Association policies. Their role is to diagnose and treat and support the patient, support the employee-employer relationship, really critical, provide the appropriate information to the patient and to the employer, facilitate, and that's an important word, facilitate the patient's safe and timely return to the most productive employment possible, and understand the roles of employment personnel and what their job is in the process. Physicians need to obtain and use subjective and objective medical, and that's something I encourage many clients to look at, is whether the physician really is getting the objective medical information. Physicians need to determine, as we talked about in the beginning with Dr. White's research, the biological, psychological, and social factors. Physicians need to ask for the actual job demands. We'd like to be able to educate physicians to be able to ask the employee to come back, to ask their employer to bring back the physical and cognitive demands of the jobs, and hopefully they have job demands analysis completed on jobs. Physicians should provide employers with the prognosis, the recovery expectations, detailed restrictions and abilities to aid in the development of modified duties. And that's where quite often we hear from clients where things fall down when they get a functional ability form back from the physician that doesn't have any detail on it. It's very difficult to accommodate the individual. And as I've talked about earlier, we'd hope that physicians are learning that you need to prescribe active treatment that includes work. Work is good for employees, assuming it is not endangering them and assuming it's within the realm of a very good program on return to work that makes sure that the accommodation is appropriate and that the job is suitable. For those of you who are employers, I instead of providing advice and bullets, what I did is I put together what I felt was a checklist. And I think for employers, if you want to improve your program, you want to improve your system, you want to make sure you're doing the right things, go through this checklist. Does the policy commit to early and safe return to work? Right through to procedures. Do you have the right key performance indicators that we talked about in place? Do you have forms? And the red letters are usually the forms that I recommend you put in the package to the employee. So any individual who says that they're injured or ill and can't return to work is going to get a package with a letter to the employee that explains to them what they need to do, a letter to the physician that explains your commitment and what you as an employer are willing to do to help the individual, the consent to release the information, and the functional abilities form. If that is given to the employee immediately and you get that back quickly, it helps with the early intervention strategy and return those individuals to work quickly. I won't go through any more of the checklist, but I also have a more comprehensive audit checklist, or that if you're interested, you can feel free to email me at my email address there. And the slides will be provided to you later if you'd like a copy of these slides. Remaining barriers and challenges. I've talked a lot about treating physicians' knowledge and capacity building. We need to continue to train, help physicians understand their role. But we need to understand how to accommodate those with mental health diagnoses. Become a big issue, very difficult to manage. We still see a big gap between the leading employers that I've talked about and those who are less sophisticated and don't have the resources that some of the big companies have or the big organizations have. Engaging supervisors is always an issue, and it's always something that we need to work more on, I think, is to ensure that the supervisor understands their role in supporting the employee, encouraging coworker support. we still see insurers who, struggling with the adjudication and claims management versus case management services. Unfortunately, there's still a lot of insurers who are focused on the adjudication and claims management piece and don't perhaps do as good a job as they could, I think, in case management. And lastly, one of the things I think that's a continued barrier and a challenge is that insurers are really motivated in many ways, for when you look at the non-OC, by long-term disability reserves is really what they want. They make their money off the long-term reserves and the profit, and sometimes they're less motivated to invest in effective case management for short-term disability claims, and that's been a barrier in several cases I've seen. Tanya, I'm willing to take questions at this point and say thank you to the group for listening to me.
Wonderful. Thank you very much. That was very good. In looking at the questions, to all of the attendees, feel free to go ahead and submit any questions that you do have. One that I have is that you mentioned the CMA has a return to work policy that is about 10 years old. Is this available to employers?
Yes, the CMA policy is available online if you just Google or go to the Canadian Medical Association. I think the easiest way to find it is just Google Canadian Medical Association Return to Work Policy.
All right.
And it's publicly available. The other thing I would encourage for employers is one of the things I've done and I always recommend to clients is when you create that letter to the physician, it's also good to take some of the key points out of that CMA policy and include it in the letter to help educate the physician on what their role is and what you're expecting of them. And that policy, when physicians do get a copy of that policy, they tend to recognize it and find it helpful.
Very good. And I'll also include a link to that return to work policy, the CMA return to work policy, in the blog post as well, just to make it a little bit easy. I did have a question in listening to the presentation as well. I was wondering what you find to be the differences in how the larger organizations handle all of the return to work and accommodation issues versus smaller businesses, and if you had any tips for smaller businesses and organizations that have some of these issues as well?
Sure. I think the biggest difference that I've seen is very simply that larger organizations tend to have the ability to hire the resources to support return to work. In the smaller companies I've worked with, it's usually done either by an HR person or a health and safety person who isn't really specializing in the area of return to work accommodation disability management. And for the larger organizations who have the resources, they tend to be able to manage this, I think, a little easier. For the smaller organizations, I guess my advice for them is the first thing that you need to do is to ensure that you have that early intervention strategy, and I think that's a real critical one. Having that package I mentioned, ensuring that you provide the package to the individual, that the program and the process and procedures and forms are designed. You can contract or hire somebody to help you design that program, make sure the right forms are in place and the right procedures are in place. And the individual who is managing it is really just managing the process. They don't have to be an expert in work disability prevention in order to manage the process. And if you do need the expertise, I think the other exciting thing is the way this industry has evolved. There are many small, large companies who provide the services today. And once you put the right process in place up front, I would suggest find some of these companies who provide the type of services that you may need, whether that be case management, whether that be providing access to providers or independent medical examinations, whatever it is. Those services are available from providers out there today, and you don't have to spend a lot of money to pick up the phone and call them. They're more than willing to try to help you on a case-by-case basis.
Very good. We have a question asking if you could comment on the role of explaining upfront to treating physicians about payment for their services.
Sure, I'll comment on that. One of the things I've said for years, and I've presented on this, and for a few years I think people really wondered what I was saying in the beginning, and that was I really strongly believe the employer needs to pay for the information that the physician is providing. And I've had many discussions with employers who say, well, that's not our role. Now, in the some workers' compensation boards, they pay for the functional abilities form and the information that you need to return the individual to work, and that's great. However, in the non-OC, the board's not going to pay for it, so I think as a company you need to pay for it. And the reason I say it's important that you pay for it is it's critical information you need to return that individual to work and to shorten that duration of lost time. And you know, a $40, $50, $60, $70 investment to get the information and get it back quickly and take it and work with it, it'll save you so much money. You know, you really only have to save 1 day of lost time, and you've paid for that $50 to $70, whatever it costs, over and over again. So I strongly suggest that you put your policy in the letter to the physician. That, as I said, you're going to explain in the letter to the physician what you're expecting and what the CMA policy says, and also to put it in, you know, what you're going to be paying, how much you're going to be paying, what your expectation is in terms of what you're getting for what you're paying. So usually it's a line that says, you know, the employer is willing to reimburse the employee for the functional abilities form if it's completed and returned by the physician. So most employers will work that way, where the employee will pay the physician the $70 or $60, whatever it costs to get the functional abilities form completed, and the employer will reimburse. And I think it's important that you communicate to the physician as an employer that you are willing to reimburse the employee for that form, so that they know that the employee's not out of pocket and the doctor's not out of pocket.
Very good. I also have 2 other questions related to physicians, but I think I can squeeze them into one. Someone asking about, they find that physicians are giving time off no matter the extent of the injury, and how do you overcome that and work with physicians? And then the other question relates directly to that, as to how do you suggest helping physicians understand their role in facilitating return to work?
Yeah, the second one is the $64,000 question, is how do we continue to educate the physicians? And I think it's done through the letter to the physician, the CMA policy. I've been involved with some organizations who have been trying to set up events for physicians to teach them. It's very difficult, and too often, too, we can't pick up the phone and call the physician and talk to them, and so it's very difficult to kind of continue to educate them. But I'm hoping that I think there was an organization a couple of years ago who started from the U.S. called the 60 Summit, that ran a session in B.C. and one in Ontario that was good and positive. I'm hoping we're going to see more of that. I know Dr. White at CIRPD has been working with some projects with, I think it's the UBC Medical School on some of this. So it's definitely a need, and it's hard to do. The other part of that question was, you know, physicians giving time off. You know, that's the age-old question we always get is, you know, how do they justify the amount of time off? Why can they say just take time off? And I think part of the answer to that is to make sure that you explain to the employee and to the physician through your communication that your philosophy is that there is never a need for time off. You know, rarely do you need time off, that you're willing to accommodate the individual in a job that is suitable and is within their capabilities and restrictions. And one of the keys to that is getting that functional abilities form back, whether it's OC or non-OC, that is completed by the physician. If the physician writes, take 2 weeks off, then you need a process to intervene and have another healthcare provider contact that physician and ask why, and to explain that you have an ability to accommodate the individual and you're willing to accommodate the individual. You know, the old stories of Dr. Summeroff, who likes to give people the summer off, or you know, those stories go back forever, and I think we'll always deal with those. But I think it's really contingent upon the employer to be able to convince the physician that you can accommodate the individual properly. And I think a lot of that too is working with if you're unionized employer, work with your union. to make sure that the union is confident that you have a program that works, that they're engaged, and that they're at the table when there are questions or disputes about whether the accommodation is suitable. The union can be a real ally in helping the individual get back to work. I've seen examples where the union has contacted the physicians and said, you know what, we have a program with the employer and we believe strongly in it, and we'd like to see this individual back to work. And I think lastly on that point, I think one of the things we have to do is explain to physicians how important it is for people to be at work, and that there is research out there that proves that if they're at work, they tend to have shorter duration of disability.
Very good. And then I had one other question. Someone asking if you can comment on the different disability management guidelines used by insurance organizations or by WCB. They've heard that Reed's disability guidelines are very good.
There's a couple that I've worked with or we've worked with in the past. One is Presley Reed, and Presley Reed has been around for years. And the other, ODG, I think it's Occupational Disability Guidelines, is another good one that we've used. One of the things that I feel very strongly about is the use of those and how important it is to, in your return to work process, to have an individual who can use those and who can interpret those properly. They can be an excellent tool for also for communicating to the physician that the individual's recovery is maybe not optimal. So those are two examples. I'm not sure exactly what the boards are using now, to be honest. But most clients that I work with, or most companies that I go into, particularly when I go in to do an initial gap analysis or audit, the service that we offer, most companies don't have any idea what the guidelines are and don't have anybody who knows how to use them. So for employers, I think it's something that needs to become knowledgeable on and get folks who are trained and have the ability to use those. And providers of those guidelines actually provide pretty good training as well. So if you purchase access to those guidelines online, they'll provide training to you as well.
Wonderful. That's great. Well, thank you very much, Doug, for the presentation. And we're very glad to have you with us. And thanks to everyone for joining us.